Leader?
I'm ready when you are.
All right, very good.
Hello, everybody. Thank you for coming out today for our second book sandwich in of the season. I'm Medina Viviani, and I'm the programming librarian here at BML. And just to start with a few housekeeping announcements, please silence or turn off your cell phones so as not to disrupt the speaker. If there is a need to evacuate the building, the door on my right, your left, is the closest exit. And please wait for the microphone to reach you if we have time for Q&A at the end so that everybody can hear and participate. We do have an induction loop option. If you need to turn that on for hearing aids, feel free to do that. And I want to thank the Friends of Bright Memorial Library for sponsoring our series. We're very impressed with our book selection this year, as you can tell by the fact that we have hardly any copies available to check out today. So please, if you do see a book that you'd like on our BSI flyer in the back, you can ask at the info desk. We can place some holds for you so that you can read all of our great books. All right, and
What?
Thank Friends for the smart board.
Oh yes, and thank you, Friends, for the smart board. It's our brand new technology, and the doctor is our second presenter who is going to be using it today. So I love our nice crisp screen. Very excited about it. So thank you, Friends, and anyone who would like to ever help out the Friends so that they can help us out, you can check out the book sale happening in the Friends bookstore in the rear of the library. All right, thank you, Jennifer. All right, our presenter, Dr. Michael Mendoza. He is Senior Vice President and Chief Operating Officer at Trillium Health, which is where I nabbed and kind of shrunk down his bio because he has many more accolades than I will just mention here. He's responsible for Trillium Health's strategic framework, collaborating with leadership to increase access to programs and services, promoting operational excellence, and managing resources to help the organization achieve its goals as a federally qualified health center. Dr. Mendoza is also professor in the departments of Family Medicine and Public Health Sciences at the University of Rochester School of Medicine and Dentistry, and he recently served as the 9th Commissioner of Public Health for Monroe County. During his 8-year tenure in this role, Dr. Mendoza was a leader in the county response to the opioid overdose and outbreaks of Zika, measles, and COVID-19. Dr. Mendoza has worked as a primary care physician for over 20 years and joined the faculty at U of R in 2009 and was appointed to serve as medical director at Highland Family Medicine. He's held numerous board and committee roles and still does at state and local levels. He is originally from Chicago, and he received multiple degrees and training from University of Chicago, University of Illinois Chicago, Simon Business School at U of R, University of California, San Francisco, and the Oregon Health and Science University. In his spare time, the doctor enjoys spending time with his kids, his 2 golden doodles, running, cycling, cooking, photography, and DJing, mostly 80s and 90s music, which we'll have to catch up on another time. Thank you, doctor. Thank you all for coming. I'll turn over the mic.
Thank you. Thank you. It's good to be back. I feel like every time I come here, there's a crisis happening. The first, I think, was the opioid. We were in the middle of the opioid crisis, and we're not out of that yet. I think the second time I was here was sometime during COVID, which was a blur to me, maybe for many of you. And now I guess I will say that we are in a different crisis in health. One that is more existential, I think, in many ways than any of the prior 2 that I've had the opportunity to work in. So I feel like my work is not done. As you heard, my work now takes me to Trillium Health. I joined Trillium in January. In many ways, it's a full circle sort of situation for me. I started my career working in a community health center, FQHC, on the south side of Chicago. And here I am again, 25 plus years later, working in a very similar circumstance, working with underserved people, trying to advocate for health equity and health justice and social justice. But now I would say in a time when that is even less fashionable than it was before. So we'll get into that. We only have an hour. My hope is that I don't talk for a whole hour. I enjoy this opportunity because it gives me a chance to hear from all of you and hopefully for you all to hear from one another. And so if there's anything I can do to engender a spirited debate, conversation, dialogue. That's really my goal here today. So the reason I came here was to help review this book right here in front of me. I thought it would be helpful to talk a little bit about tuberculosis, primarily from a medical and scientific standpoint, just so we have some common understanding of what tuberculosis is, and to address some of the concerns raised in the book, which is that there's a lot of misconceptions and stigma around tuberculosis. And so if there's anything we could do to break down that stigma, I think that would be a good thing. We'll then talk about the book. The book struck me for a lot of reasons, and most of them were for the non-medical reasons. You all may read this book and find the medical pieces more interesting. It was interesting, but it's also stuff I've learned about before, so I didn't find that as intriguing as the social and the political and the economic themes that the author raised. And then I think we can spend more than an hour alone talking about the lessons that this book raises. So first of all, tuberculosis. Just by show of hands, do you or anybody you know have or had tuberculosis? Active tuberculosis? A few.
I worked with a baby in London in a mother's home who ended up with TB meningitis, I guess,
Ooh.
and became deaf.
Oh.
I don't know quite how she got it.
We'll talk about that. We know how she got it. Where is the question? So tuberculosis is actually quite common. Much more common in other countries than it is here. And by common, I mean active tuberculosis. But latent tuberculosis is very common here in the United States. And that's a common misunderstanding that I hope to clarify for you all. But just to start from the beginning, tuberculosis is a bacterial disease caused by Mycobacterium tuberculosis, which was discovered in the 1800s by Edward Koch. It is one of the unique bacteria in that it thrives in many environments, both in the body as well as outside. And within the body, it gets extremely complicated because although it primarily affects the lungs, as you heard, it can affect almost anywhere in our body. It is spread primarily, exclusively through airborne contact. Bloodborne contact transmission is very, very rare, primarily through airborne when an active person with active TB is coughing or breathing. Extremely contagious, extremely contagious. Once it's from an active patient, they can spread it to multiple people at once. And all it takes is a cough, a sneeze, or even speaking. But the reality is that not all people who are exposed get sick, which makes it very interesting and difficult at the same time from an epidemiological perspective, because you can't do the traditional contact tracing that you might find with something like measles or even syphilis or herpes infections, where almost everybody who is exposed demonstrates some sort of symptoms. In tuberculosis, not everybody who is exposed will necessarily develop symptoms. So the infection begins when the bacterium infects our lungs, the small, tiny air sacs in our lungs. The immune system's response in general to tuberculosis is to try to wall it off. Our immune system has many different ways of fighting infections, and it all depends on the pathogen. In the case of tuberculosis, the body's desire is to initiate an inflammatory reaction that literally walls off the infection as best it can while it tries to kill the infection. So if the body succeeds in this, then the person is considered to have latent TB infection. So they never develop symptoms. The body was successful at compartmentalizing it, walling it all off, so that the bacteria don't have the ability to initiate all the other sickness symptoms that we know of. But if the bacteria breaks free, then you have active infection. And this is what gives us the typical symptoms that you would know of in tuberculosis. So as I mentioned, a person with tuberculosis can infect, depending on airflow, depending on the environment, the physical environment, between 10 and 15 people in a year, which may not seem like a lot, but when you do the math, if one person infects another person and that neither of them know it, this is just a multiplication problem at this point. You can infect hundreds of people. And tuberculosis is one of those things. It's a roll of the dice sort of situation. Not all people will get sick, but some people will get very sick, and consequences can be fatal if you're not appropriately identified and treated. So just to give you a little bit of the medical side of things, on your left side is a chest x-ray of a person with tuberculosis. The white splotches, if you can appreciate that, normally the lung fields are a homogeneous black or dark gray. You shouldn't see the level of white splotches that you see on the left side. So those left-sided, the splotchy things on the left side of the chest film are granulomas. That's a sign that the body has succeeded in walling off that infection, and those cells show up as more dense on an x-ray because they're filled with cells and water as opposed to air. Air shows up as black, solid things show up as more white, and obviously the most solid things, which x-rays are good for, are bones, which is white. So that's the gradation there. So when you see something that's sort of white, that's a blob, a squishy blob, a cellular blob. And on the left side is a CT scan, which is essentially a chest x-ray that's done in multiple cuts through our body. And ordinarily that's primarily black with small white dots, which are blood vessels in this case. But here you see on the bottom left side, which is the patient's right and the posterior side, is that large granuloma. So that's a big TB infection that was walled off. And even now, you will find people who are typically from foreign countries, although not exclusively, who will have a chest x-ray and it'll show biapical scarring. You'll see biapical scarring. The apices of the lungs are toward the top. That's where there's lower oxygen content. That is typically where the mycobacterium likes to go to in the lungs because it doesn't need as much oxygen to thrive. And so that's typically where you'll see signs of scarring in somebody who's had a prior TB exposure. So just to drive the point home, there are, again, two types of tuberculosis. There's latent TB infection, LTBI. So many of you may know of or even have this as part of your history, latent TB infection. It's dormant. When we find somebody with latent TB, we treat that even though they don't have symptoms, because the goal is to stabilize their immune system and that infection so that it doesn't activate. So anything that is latent, whether it's TB or syphilis or shingles, lives in the body in a latent form. We don't want it to activate, because when it activates, you get what's on the right, which is active TB. People with active tuberculosis, and I've seen a number of people throughout my career, fevers, chills, nausea, weight loss, night sweats, and that productive cough. Sometimes they can produce even like tinges of blood, is quite common in people with active TB. And no talk that I give would be complete without a comment about protection and prevention. This is an example of promotional material that was released by the New York City Department of Health and Mental Hygiene. And they do a lot to try to prevent the spread of TB. As an international city like New York City really is, although all of our cities are international, they really want to do what they can to educate people to prevent the spread of tuberculosis. Because as you can imagine, especially in tight quarters, which we'll get into when we start talking about the book, subways, you name it, in New York City, the density of population is so great that spreading TB is actually quite easy. But thankfully, we screen. So many of you probably have gotten a PPD test. PPD test is a tiny inoculum of the antigens that are in TB, meant to elicit a reaction. So when you have a positive PPD, you have that induration, that red scar, which is basically the body telling us that that person has been exposed to TB, because there is an inflammatory reaction that results when you give somebody that inoculation. So we screen them, we put them on the prophylactic medication to prevent them from activating their TB. And if we can do that on a population basis, that's how we stomp out tuberculosis. And we've largely done that in the United States. But unfortunately, there's a lot of stigma around TB, and that results a lot from historical reasons, and we'll talk about that in a little bit. But on the global stage, TB is very, very different. Tuberculosis globally is estimated to infect about 10 million people a year. 10 million people a year across the globe, and more than 1 million deaths per year across the globe. So this is far more common than than HIV, far more common than many infections that we think about. And what's really challenging, which is actually true for a lot of infections, whether they're viral or bacterial like in TB, is the concern with drug resistance. Now, this is a concern everywhere. This is especially a concern here in the United States when we talk about regular bacteria, because of the preponderance of antibiotics, broad spectrum antibiotics being used for common infections, over prescribing of antibiotics. We're seeing drug resistance emerging for a lot of bacteria, even here in the United States. Having said that, though, I'll add that it's not just human antibiotics that make a difference. If you think of agricultural uses of antibiotics, that's at least half of the antibiotics that are circulating in our environment. And so farmers and all of the efforts to eradicate germs in our food supply also have an impact on antibiotic resistance, especially here in the United States, because we're a world leader in the use of antibiotics for that purpose. So drug resistance is a real concern. TB and HIV infection, co-infection in the same person, is a really big challenge, especially in the areas where TB is most common, and we'll get into that. Because as you can imagine, if the body's goal is to activate the immune system to wall off tuberculosis, if you've got an immune system that is weakened by HIV, you're not able to wall off the TB, and you're much more likely to have active spread of tuberculosis. And so for everything I say here, it's 200-fold more important in other countries. So just think about it in that way. This is how mortality differs across the globe with regard to tuberculosis. In sub-Saharan Africa, you're 119 times more likely to die from tuberculosis than here in North America. And I won't read the rest, but huge disparities in mortality rate. And as we'll talk about later, and as we'll talk about especially here in the United States and closer to home here in Monroe County, these disparities are complicated, are multifactorial, and I would say largely preventable. If we have a world, if we have a system that is truly equitable, there are no health disparities. And we do not have a world, and we do not have a country or a state or a county that is equitable. We do not enjoy health equity here in Monroe County, and we'll talk about that if there's time. Here in the United States, cases are somewhat on the rise. This is relatively small in terms of numbers of people infected. In 2024, there were just north of 10,000 people with active TB. Not that many when you think of a population the size of the United States, which isn't meant to minimize the impact of the illness for those who have it. It is a very big deal, and we've managed a lot of cases here in Monroe County where it is very, very complicated. But it is somewhat on the rise. And you have to ask yourself, is there something biological about tuberculosis that has made it more common? An 8% rise over 12 years is significant. What has changed in the United States from 2011 to 2023? And I mean this somewhat rhetorically. Yes, some of it is the pathogen. The pathogen is evolving, is mutating, is acquiring drug resistance. That is part of it. But I don't think, to be honest, that's the majority of the reason for the increase. I think in the US in particular, we've seen a change in health in our health system. We've seen a change in attitudes towards science and critical thinking. And we've certainly seen a lot of change with regard to the stigma component of tuberculosis, which factors into whether or not somebody decides to seek screening or treatment if they have symptoms of TB. So high-risk populations, not surprisingly, bear the majority of the risk. Non-US born individuals represent 76% of cases of active TB, which is 20 times more likely than those who are native to the United States, currently living here. Huge geographic disparity. I don't know why Kansas is at the top of the heap. There you go. And public health interventions are really important. And I will say that here in Monroe County, we are blessed because the Monroe County Health Department's TB program is led currently by Dr. Paul Levy, who is a pulmonologist, who is a former chair of medicine at U of R. Not a lot of local TB prevention units have the luxury, like we do here, of being led by an expert in TB. You know, many times as a physician like myself or a general internist who's generally aware of TB, but Dr. Levy is an expert in TB. I mean, he could have written this book. In fact, when I learned about this book, he was already reading the book, and he could have easily written a book just like it. This is how many cases of TB we've had in Monroe County, dating back to 2013. Generally on the decline. I will say that with numbers this small, it's very sensitive to our data surveillance systems. In general, because tuberculosis is publicly reportable, it's by New York state law. If somebody has tuberculosis, the local health department should be informed of it. So we shouldn't miss cases here in Monroe County, but I'm sure that there are some that somehow escape. Any questions about TB? That's not why you came here. We came here to talk about this book. And as I alluded to earlier, I think the book is a must read. Whether you have a strong interest or not in the microbiological aspects, which I think many people will have. I think there is a general familiarity with tuberculosis from a medical and a health standpoint. But what I really enjoyed about this book was reading about how ubiquitous tuberculosis is and has been in the course of our history. And we'll talk a little bit about that. The author is a self-proclaimed nerd. I think he uses the word somewhere in his book. And he lives. He really lives tuberculosis. He talks about how he sees remnants of the impact of TB on society in many facets of our society even now. And I think he does a really nice job dehumanizing. So I think I use this word later on, but the point is when you have a double negative, it's humanizing people with TB. I think he goes to great lengths to try to break down the stigma that has evolved over the centuries around tuberculosis, and we'll talk a little bit about that. But I think he does a really nice job, particularly in the time that we're living in now, looking to the disease and looking to those who struggle with the disease, not labeling them with their disease, but thinking through, these are people, these are our family members, our relatives, and so forth, who are struggling with an illness. And that person can come from any demographic. And so to the extent that we can humanize illness of whatever type, I think that's a big emphasis that the author makes during this book. He's got a strong emphasis on global health, which is not an area that I'm that expert on, other than to say that what we enjoy here is a luxury. For all of the things that we can complain about and struggle with here in the United States, we have the luxury of scientific discovery and a workforce that's like no other in the globe. We're also the most expensive healthcare system on the planet, which has its own problems. But I think in general, we enjoy very good healthcare here. Big advocate for health equity as well, as I am. The author goes to great lengths talking about his experiences in Sierra Leone in 2019, which is what spawned this book. And what really spawned this book was meeting a child or adolescent at the time with tuberculosis. And we'll talk a little bit more about Henry, but tracing his illness, tracing his life with the illness, and Henry's ability or not to navigate the system in Sierra Leone really underscored for me how important it is to advocate for global health equity even outside of the United States. So, obviously this is a talk about tuberculosis, so that's the punchline here. But an Adirondack chair, cowboy hat, founded by Stetson, which is not just a cologne. Is that still a cologne? It was a cologne when I was growing up, I remember that. Pasadena, California, and the murder of Archduke Franz Ferdinand, which kicked off World War I, they all have common ties in tuberculosis. So the Adirondack chair was developed in the Adirondacks and was a fixture of sanatoriums, places where people were sent from the city, which at the time was New York City. They were sent to heal. And you can read that in a lot of ways. On one hand, there was an epidemiologic principle. It was contact isolation. It was quarantining, and that's very well rooted in epidemiology and public health. But there are also social overtones to that, which at the time, most people who were sent to heal in the Adirondacks were white and wealthy. So it's a very different picture than we might think of in today's high-risk population. So Adirondack chair was literally developed in the Adirondacks and was a relatively affordable way to allow people who were living in these sanatoriums to go outside and enjoy fresh air. Because at the time, they didn't have antibiotics. And so fresh air and sunlight and the birds and you name it, nature, was viewed as therapeutic, which isn't wrong. It's not enough, but that in the time, so Adirondack chairs found their roots in the Adirondacks around tuberculosis. And I have another picture to show you that in a little bit. Stetson had TB, and he invented this hat because he rode his horse across the country and needed shade, and literally invented this hat. But the point is that Stetson had tuberculosis, and he invented the modern cowboy hat in response to his need for some shelter as he was traversing the country on his horse. Pasadena, California was a common destination for people with TB. And so if you visit Pasadena, they have many, many artifacts and historical monuments to the tuberculosis movement, if you will, from east to west, because in many ways, people didn't stop at the Adirondacks, people kept going west, and Pasadena was one of those places. And how might Archduke Franz Ferdinand play into this? Well, he was murdered, as you all know, and his two assailants had tuberculosis. These were two teens who had TB, who knew they were dying. At the time, it was almost always a fatal illness. And they decided that they would rather, roll the dice and try to murder Archduke Ferdinand than to have to endure their undoubted fate with tuberculosis. So I just happened to be at the Cayuga Nature Center in Tompkins County last month and came across this sign, did not even know it was going to be there, but at the Cayuga Nature Center in their parking lot, they have a sign, and they called it was, at the time, summer camp for people with tuberculosis. It was established in 1914 and essentially moved and closed, and that sign is still literally there. That was a month ago. So the part that I really found interesting about tuberculosis in the book were how he talks about tuberculosis through history. And he has an archaeological, some archaeological comments, and he talks about how it was first discovered in bone samples collected from Neolithic human settlements. And so as I mentioned earlier, tuberculosis can infect literally every part of the body. A common part that was infected was bones. And so what you see there on the left side of that top picture is a person's spine. As you know, the spine should be mostly straight with very intentional curves. This is an AP view, so this should be straight on, up and down, straight. And as you can see, it's not. What you may or may not be able to appreciate are the porous little gas bubbles in the bone. That's not normal. And this can happen when tuberculosis infects the bones. The body tries to wall off the infection within bone. And if it's successful, great. The problem is that you've just weakened the bone, because now in place of bone and calcium, you've got air, which makes like osteoporosis for a weaker bone. The Code of Hammurabi, even older, they talk about lung wasting disease and all the various treatments that they had for that. That was written into the Hammurabi Code. The Greek physician Hippocrates called it phthisis. So the first 4 chapters, I don't even think the author calls it tuberculosis. He refers to it as phthisis, which I spelled there for you, which is oddly only 2 vowels, but it refers to wasting, because at the time it was an illness that was seen as a way of the body wasting away. Later writings about tuberculosis throughout the industrial age and so forth refer to it as the white plague, referring to the people who were largely infected with tuberculosis. And we'll talk about that. And a common name, and even today I hear some patients talk about it as consumption, because the idea is that the illness is consuming in many, many ways. The author really spends a lot talking about the romanticization of tuberculosis, because it was so poorly understood until really the late 1800s, and yet present in society for centuries before that. Many artists took to their medium to depict tuberculosis in a variety of ways. And because it was so poorly understood, because it infected largely at the time the elite, so people who lived in cities considered to be the elite were the ones who were most at risk, just because of the proximity with which they lived in contact with other people. It became known as an illness that targeted the rich and wealthy and elite people. So it's very different than common conceptions of chronic illness, where we tend to think of them as disproportionately, and they do, disproportionately impacting minority populations. In this case, it was very distinctly a majority population that was at greatest risk by virtue of their environment. But in their goal, and in the artists' minds, and their goal to try to make sense out of this thing that nobody understood, they took to artwork. And there are just so many examples of art that depict tuberculosis in a variety of ways. In this one, you see a figure, a beautiful woman dying of TB. If you read the bio on this photo, this is a patient dying from TB. And she's meant to look, beautiful and voluptuous and peaceful and all of those things. And this was society's effort to try to find a way to normalize tuberculosis, because they didn't have any other way to do it. So they celebrated tuberculosis because there's nothing else you can do. And the author critiques this because he talks about how this evolved into stigma. And it's an interesting sort of dichotomy. When you read the book, you'll see how he develops this notion of stigma throughout the book. I would say it's probably one of the most pervasive themes throughout the book. It happens to coincide with a lot of my sort of way of thinking about health, because stigma and injustice are a pervasive theme when we think about health. And I think the author does a very nice job calling out that stigma with regard to tuberculosis. So this is a painting from the late 1900s. Edvard Munch, who many of you may know from Scream, the screaming photo. He took a different, if you look at his artwork, it's less than calming. He takes a very different approach to depicting tuberculosis. And here is a person on the left who is a child, a daughter, I think, of a person who is dying from tuberculosis, and their mother there on the left. And so this is a different depiction. Again, white people dying, but again, a depiction of tuberculosis that's humanizing in some ways, but also stigmatizing in other ways. The author also spends a lot of time talking about global health, and we'll get into that when we start talking about Henry. But he talks about his time in Sierra Leone. He spent a lot of time in that country trying to navigate the system through the eyes of many people who were infected with tuberculosis. And he has a lot of familiarity, being from the United States, with our health system. And he draws a lot of parallels and contrasts between our system and theirs. We'll talk about Henry in the next slide. The other thing that the author talks about in his sort of ethnography of tuberculosis in Sierra Leone is how they, like us, lacked innovation to preventing and treating tuberculosis. For all that we can do in the United States and globally with many infections tuberculosis is still one where in many ways we're in the dark ages. So if you know of anybody who's received treatment for TB, it's like 3 or 4 drugs. You know, we've managed to, for HIV, for those of you who remember the early days of HIV, treatments were 4 drugs 5 times a day. Now it's 1 drug maybe once a month if it's injected. So we've come a long way with HIV. We have not made nearly the same progress with tuberculosis, even though it's been around, 100 times longer than HIV has, to our knowledge. And even right now, people who get treatment for TB receive 3 or 4 drugs for active TB, 3 or 4 drugs. We have programs in the county where we directly observe people for treatment. This is another whole aspect of TB. But we haven't developed the level of innovation for preventing and treating TB like we have for probably any other illness that we care for in modern medicine. So that is something that the author is very critical of. Apart from the historical and the artistic and the social part of the author's book, I think the facet that is most heartwarming, if I will, to me, was how he talked about Henry. He spends a lot of time humanizing Henry, talking about his personality and his smile and the way he interacts with people. Just a boy, a youthful, joyful boy at the time. And I won't spoil it for you, but he talks about Henry's life course with the illness, navigating life, both from a medical standpoint and from a social standpoint in Sierra Leone with HIV. He talks about drug resistance. He talks about the challenges that Henry experienced with accessing medications, with taking the medications as prescribed. As you know, with a lot of illnesses, if you stop taking your antibiotic, you give the microbe a chance to mutate and develop resistance. So whatever you just used to treat that infection may not be effective the next time you try. And when you've got to treat somebody's infection for 9 months, I won't ask for a show of hands because I know the answer. When you're prescribed a course of antibiotics, do you always take every pill? And we know that many people don't take the last pill or more. We just know that, and I won't even ask. But it's and that's for a 10 or 14 or a 3-day course. When we do studies of treatment for UTI and we ask how many, you've gotten 10 pills, how many of them did you take? It's not 10, and that's just for a 3 or 5-day course. Imagine having to take antibiotics for 9 months. Most people will miss something, we know that. And so he talks about how Henry struggled when you don't have clean access to food and water and shelter and all those things, how hard it is to be adherent to a treatment that's 9 months long and multi-drugs. And so he doesn't blame Henry for the development of drug resistance. The author really ties it to shortcomings in access that are largely driven by social norms and economic norms and environmental factors, and not a person's lack of being a good patient. That's a view that I personally want to get rid of, because I don't think patients should be blamed, really, for most things. And the author spends a fair bit of time talking about global health inequities and the economics and the health systems, and that's important as well. But I think his primary goal is to inspire a level of empathy for people who struggle with any illness, and in this case, TB. And the author is not shy also about his belief that we should all be engaged in grassroots movements to advance health. He's not apologetic at all. He's very, very forthcoming, in fact, about how important it is, whether you're in a global health setting or right here in Monroe County, that we get involved in advocating for health. This has been a focus of mine for most of my career, personally. I'm not done. We are not done with this fight. But he does spend a lot of time talking at various points in the book, whether it's the way emergency departments in Sierra Leone are situated to or not to help patients who have emergent needs, whether it's here in the United States, same problem, honestly. whether it's access to drugs, to pharmaceutical products, very challenging in some ways in foreign countries, but in some ways it's not. HIV medications are a lot cheaper outside of the United States in some regards because the manufacturers have a different pricing model. If you go to Canada, medications cost different. There's nothing different inherently about the medication between here and Canada. It's just that the health system that is supporting or not that drug is very different. And so the author spends a fair bit of time criticizing those differences. But at the end of the day, I think he says, he really wants us to be thinking about the equity aspect of health, thinking beyond personal experience with health, whether it's TB or otherwise, thinking about the system that supports or doesn't support equity in health. So in my closing moments, I don't give talks anymore without talking about disparities. And I want to take a sort of side tour here to talk about disparities here in the United States, because I believe that in a society like ours, we shouldn't have health disparities, period. And if there was one thing that I struggled with in my role, especially at the health department, was waking up every day knowing that there are health disparities, that anything that I did or didn't do wasn't going to impact the public equally for reasons that were completely beyond me. And as much as I tried to understand them, there was nothing I could do about the fact that poverty and racism have taken root over centuries in this country and are probably the reason for most disparities in health in this country. If you ever hear the term social determinants of health, when I teach at the medical school, the medical students are very well versed in housing and food and transportation and environment and air and all these things that are very important to health. And poverty and racism are the reasons why there are different levels of access to all of those things. I don't think, and I've challenged every audience I've spoken to in the last 10 years, please tell me if you can identify a factor that doesn't find its roots in poverty or racism, or if you can think of something else that can explain differences in access to health that are not poverty or racism, or both. So, a health disparity is preventable. If there's nothing else you remember from this slide, know that health disparities are preventable. Health disparities occur when there's a difference in the burden of a disease, whether it's heart disease or diabetes or high blood pressure, or other conditions that impact health. All right, a difference in burden of other conditions that impact health, whether it's injuries or violence, and you see disproportionate prevalence of those conditions between populations where there's a higher prevalence in those who are generally disadvantaged for some reason or another. They're preventable, not easily preventable. Definitely not easily preventable, but these should be preventable if our system and our society are constructed such that we are aware of these disparities and we actively work to fight them. They're not random, okay? We can't do anything about random because random's random. These are things that are not random. These are things that we can control if there's a will, which I will say we don't have collectively right now. So to give you an example, okay, so when you look across the globe, maternal mortality defined as death of the birthing person within a year of their peripartum period, the United States has a very high maternal mortality rate, much higher than other developed countries in the world. That is a form of disparity. It's not a true disparity because you really can't compare the US and France because none of us have the same health systems really. But when you look within the United States, you see a disparity because there's a difference in maternal mortality when you look at Black women versus white women versus Hispanic women. In general, as a population, all people live in the United States and to some degree enjoy or not the same health system. And this plays out when you look at Monroe County, when you look at New York State, when you look at any geographic area, you see, maybe not this severe, but you see the same disparity. For maternal mortality, Black women have a higher mortality rate than white women do. Infant mortality, same story. The United States ranks pretty low in the world with regard to infant mortality. So this is death of the infant within a year. The United States is in the bottom third for sure, and we can talk about why. But again, there's a disparity in infant mortality between white babies, Black babies, Native American babies, and so forth. And it's to the tune of 5 to 1. This shouldn't be. This should not be. And so we see the same thing with TB now. There are disparities in screening. If you think about when are most people screened for TB? Related to work. How many of you work or know somebody who works in healthcare? You got to get an annual TB screen. If you're any kind of human services, there's an annual PPD screen. It used to be a PPD. We don't have to do PPDs anymore, but there's an annual TB screen. It's a luxury of working that from a public health standpoint, we screen people for tuberculosis. That doesn't necessarily exist in other parts of the world. Okay, so that's a difference between us and other countries. But even here within the United States, if you don't work or have a reason to have a pre-employment TB screen, you won't have a screen. Because most people don't tend to get screened here unless it's related to work or because most people don't, it's hard enough to get people to say, I want my flu shot. You hardly ever people say, I want to have a PPD. People don't get them because they want to, they get them because they need to. And that is a feature. On one hand, it's a good thing because otherwise we wouldn't be screening anybody. But on the other hand, it's a luxury of working that by itself creates a disparity because somebody who's not working, that's a different demographic, they're not getting screened. And then when you look at our policy, and this could be a long talk, when you look at how our administration now is viewing foreign aid, the U.S. Agency for International Development was gutted earlier this year. Most scientists think that there will be a 30% increase in tuberculosis cases globally because of the USAID's inability to do the work that they've been doing all along outside of our borders. And that's not a political statement, that's a fact. That's a scientific fact. And while we're on the topic of science, the alphabet soup there at the bottom, we're entering the respiratory season for flu, COVID, and RSV. And the New England Journal just on Friday published guidelines for how to manage all of these things because we don't trust that the CDC will do that this year. I can't remember a time in my career when, and New England Journal is reputable, but I didn't look to the New England Journal for public health guidance. We looked to the CDC. And the portion of the CDC called the ACIP, the Advisory Committee on Immunization Practices, was just gutted and replaced with, I shouldn't be too judgmental, some of those people are scientists. And so we can talk about what science is, but in general, when I think of a scientist, I believe they should be versed in the scientific method, which is a thing that we learn in school that many of us are intrinsically aware of. But when you don't have it, you don't know it. And when you are given a platform like this and you don't know what you don't know, all you do know is what you do know. And if that's what you build policy on, that's a dangerous concoction. And that's what we're living in right now. Whether it's the CDC or the ACIP or the Food and Drug Administration, the absence of science right now is concerning to all of us in medicine. So I will pause there. I want to invite questions, thoughts, comments from the floor.
Does anybody have a question?
Can you be cured of TB?
Yeah, sure. You can be cured of TB. If you take the prescribed regimen of antibiotics, yeah, it's curable. Not easy, because it's 9 months of multiple medications. but it's curable.
I'm gonna.
Cases for immunization, or how many patients do you have?
So, what is it called? Other countries have been trying to immunize against TB. I'm blanking on the name of it now. Oh, goodness. BCG. It's a form of TB that was chemically altered. It was an effort to immunize. And so people, foreign-born people who come to the United States who've received the BCG vaccine, because it's a form of TB, we can't do the PPD on them because it's always going to be positive, but it doesn't necessarily mean that they were infected. So BCG was an effort. It's not generally effective. It's in foreign countries it works because access to treatment and screening is harder, but it's not generally effective enough for us to call it a successful immunization program, especially here in the United States. So there have been efforts to do that, but it just speaks to how hard it is to prevent this illness. There is no vaccine for TB.
Is there someone over here?
Just to follow up a little bit on that, can you comment on why either you or this author has not, or what you or this author might think about why there has not been more modern research into a cure for this long standing illness?
It's a really good question. I would suspect, for myself, I think that there isn't the level of interest here. And by that I mean there isn't the level of potential profit here to try to treat this thing. Because as you saw, there aren't that many people in the United States who struggle with this. And to develop, and if it was easy to develop, it would have been developed by now, because we've known about TB for centuries. I don't think there's a level of profit, to be frank, in developing a drug that is more easily accessible to people. If you really want to get into another talk, it's all about the money in medicine. So as much as I'm a doctor that cares about people, I have to remember that I live and work in a system that's all about the money. So
I can talk to that. So we've never met, but my name is Marty Peralta. I'm actually a TV researcher at Tuberculosis.
cool.
Oh.
You should be giving this talk.
No, this talk is great. The book is awesome. You really should get the book. My favorite quote in the book, I'm paraphrasing, and you kind of position it. He said, the disease is what the drug is not, and the drug is where the disease is not. And that's tuberculosis in a nutshell. And actually, I bought this book at Saranac Lake. So if you've ever been there, the Stroh Institute is there. I just spoke there this summer. I went to the museum, the Saranac Laboratory. It's great. So Ed Livingston Trudeau formed that sanatorium out there. And since everything is tuberculosis, his grandson is Gary Trudeau, who did Doonesbury. So
The Doonesbury guy.
Yeah. So there's actually Doonesbury, and if you go to the gift shop, you can get a Doonesbury thing that shows the Trudeau Institute. And they have that book there, and the laboratories there. So
That's
it's a
cool.
really great place to visit. And there are cure cottages all throughout Saranac Lake that were built for people to be outside.
Mhm.
We had the Iowa campus here. So if people remember before Costco, there was that building on the corner of Westfall that was a TV syndicate.
Mhm.
So we had that here.
Oh, that's good.
To your question about why people don't study this, so I've been studying this for the mid-90s, and I actually started in New York City. And the reason people were interested in studying it back then, and it was hard to get funding for it, is because there were big expansions of multi-drug resistant tuberculosis in major cities in the United States, particularly New York City. There were outbreaks in Manhattan and in homeless shelters, wherever you had people who were malnourished and crowded together, they got TB. And they were seeing a lot of NPR. So the problems with the research is it's hard to get funded. This bug grows very slowly. So if you're working with E. coli, you do an experiment in a week, that will take you 3 to 4 months with tuberculosis. And you can't handle it in the standard laboratory. You have to have specialized facilities to handle that. When I was coming up and looking for positions, there were very few laboratories in the country that have that, places that have those facilities. We have one in Barcelona, surprisingly. So you have to have special equipment. You wear button suits, respirators, the whole 9 yards. It's hard to work with. It's slow growing. You have to be dealing with infections, and the technologies used to manipulate bacteria to study them that were present in the 70s and 80s that were used in things like E. coli and Salmonella weren't useful for tuberculosis. on. But it is, TB is not a disease of the rich, so it's very hard to get funding. So while there's a little bit of there's a lot of stigma on people who have tuberculosis, there's kind of a response to people who work with it, because it's a challenge to work with it and to have facilities to do that kind of work. It's expensive, it's long-lived, animal models aren't great. Usually they do non-human primates, which people don't want to do. It's very hard to research. Mice kind of get sick, but they don't get tuberculosis like humans. So there's lots of barriers to why we don't have good vaccines. I used to do vaccine work, and why we don't have more drugs than we should have at this point. And you're absolutely right. It comes down to the bottom line of who's going to pay for it and how important it is.
Yeah. Thank you.
Thank you. Penelope, did you have one? No, you guys are good.
I hope I can phrase this question correctly. If we are potentially frighteningly leaning towards a less healthy population because of vaccine hesitancy, could that increase people's ability to contract TB if we are a less healthy population? I know that's kind of a long-term question, and I mean like next week or next year. Because you had mentioned that HIV, people with HIV tend to have it suppressed immune system. Anyway, any thoughts on that?
It would take a long time, I think. I mean, I'm more worried about vaccine hesitancy for what it represents in terms of, you know, honoring critical thinking and science. I'm more worried about it primarily from that standpoint. Obviously, the illnesses that the vaccines can prevent are another big one. You know, there are, you know, thousands of people who die from influenza every year, and we can prevent a lot of them with the flu vaccine. So yes, I'm concerned about that short-term trend. But in terms of population trends toward becoming more susceptible to TB, it would be indirect. I think our inability as a society to recognize the importance of vaccines like we used to, I think, is a surrogate for other behaviors that are not promoting health. And I think insofar as that promotes obesity or unhealthy behaviors like drinking and smoking, you know, we're seeing an increase in smoking because of vaping. We were enjoying declines in cigarette smoking for the better part of 50 years in the last century, and we're starting to see it go up again. That's not necessarily related to vaccine hesitancy. I think that's also about money. But I do think that indirectly our collective inability to recognize the value of science is going to lead toward a lot of indirect effects that will make for a less healthy population. I don't think that that's going to lead to an epidemic of TB in the United States. Around the world is a different story.
I can't remember if John Green mentioned this in his book, but when he was going to Sierra Leone, or if, say, one of us was like, oh, I'm going to go to this area that has a high amount of active TB cases, what protection would we take when we went there?
You might consider wearing a mask.
But there's nothing else they'd inject you with or give you or anything. It would be like,
I mean, remember those masks? Turns out they still work, and they always did. You know, when I see a patient in the hospital who we're evaluating, ruling out for TB, as you said, it takes, you know, a long time to culture TB. We wear an N95 mask. You wouldn't consider going into a patient's room, especially when, even with the increased ventilation and the, you know, cycles per minute, all that stuff, wear a mask.
Please.
Yeah, I can add some of it. So one of the things I really like about the book is it really tells you what it's like in the places where they have a lot of tuberculosis. And it reminded me of the stories that we'll talk to people who were out in the field in South Africa and things like that. You're talking about the nurse ones. One of the issues that they have is that a lot of the healthcare workers don't want to wear masks if they're dealing with TB patients because there's a social stigma. If you are young and you have tuberculosis and you're wearing a mask, that means you probably have HIV as well in those areas. And that is a huge stigma. And so people who have TB, and even if they don't have HIV, are told to wear masks, they will not do it. And it even applies to some of the healthcare workers don't want to look like they might have HIV as an underlying, you know, infection. So it really tamps down on even the use of masks and things where you think you would want to wear one. The stigma of that
mean, that's the reason why a lot of people didn't wear masks during COVID here. There was a level of stigma and social identity that people wanted or didn't want that was associated incorrectly with having a mask on your face or not. So that is example of how powerful stigma can be.
Does anyone else? Yeah, we can do, I've got my progressives, I can't read the clock. It's 1 o'clock, we'll do like 1 or 2 more.
What can we as individuals do to help increase the awareness of science, of, we're going the other way? What can we as individuals do to prevent that?
I think it's important for us to not judge one another. And I think it's natural many times for us to judge. I catch myself judging for whatever reason when I'm presented with something that challenges my thinking. We I think as it's human nature to jump to a conclusion because conclusions are based on patterns, and patterns are familiarity, and familiarity is comfort. That's the opposite of fear. But I think we actually need to invite a little bit of fear and a little bit of discomfort in some of our discussions. And that does mean talking to people who may or may not have the same willingness to engage in discourse than us. But I think it's through having those conversations, and many of us will celebrate a holiday later this month where we will be sitting with people who we may not agree with. And I would not walk away from that table, and I would not walk away from the discussion. And insofar as we can model respectful, fact-based discourse, I believe that's the start. It's not enough. I think on the other side of the spectrum, we have to find a way to depoliticize science. Science, by its nature, is about uncertainty, which is what breeds fear. But scientists, I believe, as somebody who does research, I invite uncertainty because it's what generates questions. And questions are the foundation of the scientific method. Asking the right question, designing an experiment or some way to evaluate that question, having data to understand what you just learned, and trying to remove bias as much as you can, because sometimes science will lead us to a conclusion that we don't want. But a true scientist will welcome that conclusion and say, yes, this is what we learned, this is what we don't know, let's keep studying. And that does not need to be political. That very process is a skill. And when I was managing COVID, the challenge was trying to convince or educate or reassure people about the inherent uncertainty of a pandemic when we were trying to encourage people to do the right thing, which we can debate now. But by its very nature, science is about uncertainty, and a lot of people just don't find comfort in that. And the analogy I use is that I don't find comfort in manipulating my electrical panel in my house. Okay, so I go to experts to do that. And I don't question their methods. I believe that a well-trained electrician knows that red goes to red and black goes to black, and much more. I'm not gonna question that. And I think it's interesting in medicine because I think medicine is among the harder fields to master. And we have, couch surfers, now purported experts in medicine. And the same people wouldn't take their electrical panel apart or undo their toilet, right? But they can somehow tell us as a field how to practice medicine. And it's a very weird dichotomy where the notion of an expert is very different now. And why is it about science? What makes science so susceptible to the couch surfer scientist when I think not even 15 years ago, scientists had a level in society and this, where we respected that in a different way than I think we do now. So I think that's a long answer to, let's try to invite that discourse. Let's not judge one another. Let's not shame one another. Shaming is never the answer. Even if somebody says something that you think is quite bonkers, try to understand where they're coming from. I hear this from patients and other, all over, and everybody believes what they believe, and there's a kernel of truth in everything that people say. In their mind, at the very least, there may not be any truth, but in their mind, there's a level of truth in what they say, because I don't think people are inherently trying to misinform. I really don't. But I do think the forces of fear are very powerful. And one of the lessons that I'm going to write about someday is that fear is how most people make decisions. Fear is what drives us to make decisions, especially in the face of uncertainty. And when you stoke fear, you get a lot of decisions, but a lot of them are not the right decision.
Thank you, Doctor. It's after 1 o'clock now, so we'll wrap it up. I really appreciate you being here. It's